Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I'm going to talk about some radial nerve entrapments. Interesting. The more you study nerve entrapments, the more likely you're going to spot them quickly and resolve them for people quickly. The nerve entrapments that I think, I'm going to talk about some of them, but there are nerve entrapments that people don't recognize, and they do what they usually do for whatever they think it is, and it doesn't work. And they're baffled because it works on so many other people, and they're doing what they normally do, and it's not getting better. So that's typically what I used to see when I didn't recognize nerve entrapments. Why did that sciatica patient not get better? Why does that person have numbness on their lateral thigh? I'm treating the vastus lateralis and it's not getting better. Let's see, there are just so many things. Well, the radial tunnel stuff I'm about to talk about. Why does that tennis elbow not get better? Why does that de Quervain's not get better? So just this week, I treated with success, by the way, with improvement on all of them. Two elderly patients with foot neuropathies, a patient who's had Bell's palsy for 6 weeks, lateral femoral cutaneous nerve entrapment for one of my regular patients. He felt 80% better after just one treatment. Sciatica all day long. So many nerve entrapment. Migraines. One of my patients went to her neurologist for trigger point injections, and she said after the injection, she felt during the injection that the nurse practitioner had been in a hurry and didn't seem very focused, and she felt like the treatment was off, not normal. And when she went home, she was having palpitations and anxiety, and then she had headaches for I think 2 or 3 days constantly. And she saw an appointment open up on my schedule and got in, and it was the day before she and her husband were going away on vacation. And she comes in, and her upper traps were crazy tight, and it was that hard ropey band in the front of the upper trapezius that goes up the neck that was so hard on her. And this is a patient that I have seen for about 2 years, every other month or so, just for maintenance, because her QL tends to get a little tight when she rides her horse. She has a horse and she likes to ride her horse, and she does some sort of competitive jumps and stuff, and every once in a while her back is acting up, so she comes in. And but I didn't know she had migraines, and she never told me. So anyway, long story short, her 3 days or 2 days of constant headaches were almost completely gone when she left my clinic, because of the migraine protocol that I use, which is based on nerve entrapments. So I just can't emphasize enough how important it is to learn about peripheral nerve entrapments. And as you know, my favorite resource is Dr. Andrea Trescot's books about peripheral nerve entrapment. So I'll put a link for her book in this episode. I probably should be putting a link more regularly for her book because it's gold. So, deep branch radial nerve. So the radial nerve, right? So it comes off the cervical spine. You have the brachial plexus. So imagine these nerves coming off the back and going kind of down the side through the scalene area, and then they go under the clavicle in the thoracic outlet under the pec minor. And so the median and the ulnar nerve are going to go toward the armpit and into the inner arm where that axillary artery is, that area. The radial nerve goes further out laterally behind the shoulder to innervate the triceps. So then it's going to run down the triceps, and especially the lateral head of the tricep is where the deep branch radial nerve is going to go. And so that lateral head of the tricep is the first location where it could get an entrapment after the thoracic outlet. So thoracic outlet is always considered. Cervical stuff is considered, especially when it's bilateral, but always look for thoracic outlet because even a small amount of impingement there can increase the symptoms of the more distal entrapments. So lateral head of the tricep is the first place you're going to think about after the neck and the thoracic outlet. And then the deep branch radial nerve is going to go in front of the lateral epicondyle through the brachioradialis, and it's going to go through the radial tunnel, which I will explain in a second. It also is right around the lateral epicondyle and the brachioradialis. The nerve will branch off a branch of superficial radial nerve, which is the sensory component, sort of like how the peroneals have a deep peroneal that's more motor. Most of it is motor. And then the superficial peroneal, which is sensory. The superficial peroneal is motor for the peroneus longus and brevis, but it branches off as a sensory nerve into, innervating the outer part of the low leg and the top of the foot, the dorsal part of the foot. So the radial nerve is very similar in that it will innervate sensory on most of the back of the hand. The outer part is the lateral outer part is more ulnar. But the top of the back of the hand is going to be radial nerve. Most of the muscles, interestingly, of the back of the arm, the hairy part of your arm, most of those muscles are innervated by the radial nerve. So it's just good to know something like that because it helps you in your assessment when you see weakness on wrist extension and finger extension and thumb extension and things like that, right? Because if you know the nerve, then you know where to trace it that you could find that it might be getting some entrapment. So interestingly, radial tunnel pain is a bit controversial because the deep branch radial nerve is not sensory, and yet you will have pain when it's entrapped. So what they found is there's some C fibers that actually can create pain, but it's not a sensory nerve. So look at it more as the entrapment causing a situation where there's going to be some pain created by the entrapment. You've probably noticed already when you're palpating entrapped nerves, the muscle that's entrapping the nerve is going to be painful, sore or painful. Also, tapping in that area can create like a Tennell's sign as well for when it's a sensory situation, which we'll talk about. So the first entrapment after the thoracic outlet is going to be lateral tricep, and then the radial tunnel is the next one, and that's the one you're gonna get as painful forearm. Some people have so much pain that they'll put their arm in a sling, or they'll hold it. They'll hold that arm with their other hand because it's so painful. When that radial tunnel area becomes really actively painful, the pain can start to go up the back of the arm and down further into the wrist area. So it can become a very painful situation. It's usually starting in the forearm extensors. So the radial tunnel, why is it called a tunnel? Because there are two. There's the bone underneath. There's muscles to this one side, muscles to the other side, and then you've got the supinator muscle that runs over the top like a little, little what do I want to say, canopy over on top, making it a tunnel. So the inner part of that tunnel is the biceps tendon, or the biceps and the bicep tendon, and the brachialis. So biceps are innervated by the musculocutaneous nerve, but the brachialis is innervated by both the radial nerve, the deep branch radial nerve, and the musculocutaneous nerve. So those are the two on the inner part of the radial tunnel. Then the outer lateral part of the radial tunnel is primarily going to be your brachioradialis, which is innervated by the radial nerve, extensor carpi radialis longus and brevis, and the extensor carpi radialis longus is innervated by the deep branch radial nerve. The brevis is innervated by a more distal part of the radial nerve called the posterior interosseous nerve, the PIN. So it's a part of the deep branch radial nerve, but it gets a separate name when it gets past the radial tunnel. I think because the entrapment gives you a different scenario of like a wrist palsy. If you have some sort of injury or entrapment of the posterior interosseous nerve, usually the entrapment is by the supinator muscle, and you will have weakness on wrist extension. And because the extensor carpi radialis longus is innervated by the deep branch radial nerve, and the extensor carpi radialis brevis and the extensor carpi ulnaris, two wrist extensors, are innervated by the pin, the posterior interosseous nerve. When the pin is being entrapped by the supinator or some lesion or something, the wrist extension will be weak, and the wrist will radially deviate on extension because it still has the strength in the extensor carpi radialis longus. So while that is considered a rare palsy, you will see it at a low level on many people if you're looking for it. If you're actually running through the exam and doing some wrist extension and looking to see if you see radial deviation, that tips you off that there's an issue going on somewhere about a third of the way down from the elbow in the supinator area. Can be 3 or 4 fingers down from the lateral epicondyle area. So for radial tunnel, the lateral epicondyle may not actually be painful. Now, radial tunnel and tennis elbow can happen at the same time. Lateral epicondylitis and radial tunnel can happen at the same time. You're, in that case, treating tennis elbow might work, and you may not even know that you just treated both tennis elbow and radial tunnel syndrome. But radial tunnel syndrome is considered treatment resistant tennis elbow. That's most likely going to be because the treatment is, besides maybe splinting, is going to be cortisone injection into the lateral epicondyle area, that common extensor tendon. So if that's not helping, then the problem wasn't inflammation, but entrapment of the deep branch radial nerve by the extensors, the extensor carpi radialis longus and brevis, and then also, possibly brachialis and biceps, and possibly supinator. So the treatment might look a lot like a tennis elbow treatment, but if you know that it is a radial tunnel syndrome, you're going to pay closer attention to things like the brachialis and the biceps tendon, because of that being the opposite side of the radial tunnel, and you'll make sure that supinator gets treated. Whereas if you're treating tennis elbow, you might treat brachioradialis and the wrist extensors, but you might not treat brachialis, or you might not treat the biceps. So that's the other consideration there. And that injury can happen to many, many people, especially people who do things like hammering, or maybe a violinist, or it could, the radial tunnel, it could happen for somebody who maybe spends long hours coding at a keyboard, or maybe it's a pianist. But when your wrist is an extension for a long period of time, that's when you're going to increase tension on the extensor carpi radialis longus, especially. The extensor carpi radialis longus has a fibrotic quality to it already. You probably noticed that when you palpate your patients. So that fibrotic quality makes it a little bit more prone to entrapment of the deep branch of the radial nerve. So the biggest test you're going to do is actually just press on what's called the mobile wad, which is that group of extensors about a couple centimeters distal to the lateral epicondyle. And when you press on the lateral epicondyle, if it's not excruciating pain, then it's very likely radial tunnel and not tennis elbow. But like I said, it could be both. The sensory entrapment, the superficial radial nerve sensory entrapment, is often by the brachioradialis and the extensor carpi radialis longus. They write down the pathway toward your thumb, toward the thumb extensor tendons that become de Quervain's. They're right at probably about 5 centimeters or 7 centimeters up from the wrist. There is this little tunnel of fascia from the brachioradialis and the extensor carpi radialis longus, where that sensory nerve comes through on its way to the thumb. So it comes really more superficial in the lower third of the arm, and that's where you can tap and get a Tinel sign if there is some entrapment there. This is a nerve that can get injured for IV. When somebody's had an IV in that area, it can become injured from a cortisone injection for de Quervain's tenosynovitis. So there's some overlap there, but that pain from the entrapment of the superficial radial nerve will give a positive Finkelstein test, just like de Quervain's tenosynovitis. The difference is going to be if you're tapping and you get a Tinel sign, then you're more likely dealing with the superficial radial nerve being entrapped by the brachioradialis and the extensor carpi radialis longus, and not a de Quervain's tenosynovitis, right? The other tip off would be if somebody with that nerve entrapment, they don't have just pain, or they don't have pain, but they have numbness on the back of the hand, back of the thumb, and the first few fingers. That is going to be a big tip off that there is an entrapment or injury of the superficial radial nerve. Numbness, tingling, and pain are all symptoms of nerve entrapment. So when it's pain, it's a lot easier to mistake it for de Quervain's. But if you're treating de Quervain's, you're treating the extensor pollicis brevis and the abductor pollicis longus. And if you're doing that and getting nowhere, then check your Tinel sign and see if you're really dealing with an entrapment of the superficial radial nerve, the sensory part of the radial nerve. Very likely that's what's going on there. So, so you see how looking at nerve entrapments is going to help you not just get results faster, but it's going to help you with the tougher cases where your usual magic tricks that work for 80 or 90% of people are not working. That's when you have to know more about nerve entrapments. This is where your manual muscle testing may not lead you in the right direction, because a superficial radial nerve entrapment is not going to cause weakness, and a radial tunnel muscle test is going to give the same symptoms as a tennis elbow. So you might be missing an important component that your muscle test will not lead you to. You have to be willing to look at some of the nerve entrapments and palpate your patient. It's always good to also ask your patient to point to where the pain is. That is a great way to figure out where nerve entrapments are happening. Your patients know what they're pressing on when things are hurting, or what they're rubbing when things are hurting. Just like this one patient that I treat him once a month to maintain not having migraines. And he came and he said, "I got something entirely new for you." I said, "Oh, good. What is it?" He said, "Well, I was stretching my hip flexor and I felt like a cramp. And now my whole outer thigh is like got burning pain." I said, "Oh, so interesting. That sounds like lateral femoral cutaneous nerve." And I pressed on ASIS and it wasn't painful, but I pressed and palpated below ASIS and found some exquisitely sensitive areas where very likely the lateral femoral cutaneous nerve was being irritated. So I just put needles in every area of that that sartorius and even TFL area where there was some soreness. And then I used the motor points of the TFL and the gluteus minimus as well, just because if he's already on his side, let's just loosen all this stuff up. And he got off the table, did the stretch. He said, "It's almost completely gone." I said, "Yeah, it might take us a couple treatments, but while I'm not seeing you, use your massage gun and work on those areas that I just showed you. And you might be able to just fix the rest of it yourself. But otherwise, I'll see you next time I see you. We'll work on it." So, when you recognize something like that, you're not trying different stuff and hoping it's going to help. Like, he asked me if I was going to need his pants to take his pants off and put shorts on because the burning was in the side of his leg. And I said, no, that's not where the problem is. Um, but if you don't know, you don't know. So, anyway, uh, I've probably rambled enough, but I wanted to cover that radial nerve stuff because I think it's important to know when something's not getting better, why it might not be getting better, and I think you'll see once you recognize these symptoms how often our patients actually have some version of these peripheral nerve entrapments. So, and by the way, it's not uncommon, especially if it starts as a thoracic outlet syndrome, that someone may also have some numbness in the palm of the hand, lateral or the dorsal part of the hand that's innervated by the ulnar nerve, because they could have a cubital tunnel and a pronator teres syndrome and a radial nerve entrapment all at once because of a long-term um, compression at the thoracic outlet. So like you've got like a neurogenic thoracic outlet starting the problem, and then you get peripheral nerve entrapments, and now they've got numbness all over, and the hand gets numb or stays numb, and it's something that we can correct when it's distal nerve entrapments like that, when it's peripheral nerve entrapments below the elbow, or it could be even in the triceps. And then, of course, if you're addressing the thoracic outlet, then they can get better without surgery. But you got to recognize it, because if you don't recognize it, that will be where they're going. They're going to surgery. Um, so anyway, I'll put the link for Dr. Trescott's book. I really think if you haven't gotten it yet, you really should. It's over $100, but I mean, it's the information you're going to learn from that book is worth, add a few zeros to that, because the amount of people that you're going to help quickly, or help that nobody else helped. That's the other thing. When you're helping people that nobody else could figure out, um, that's priceless. So, okay, I talked enough. Enjoy your day, and I will talk to you soon.